Welcome to Table Talk, the podcast series where clinical experience informs optimal human function. Today we're joined by Joshua Fein-Brown, an osteopath, naturopath and pain specialist with a keen fascination for understanding and treating pain. Joshua's approach intertwines the unity of mind and body, reflected in his work as a university lecturer, leading courses, and his commitment to community health initiatives. Welcome, Josh. I wondered if you could start by talking to us a little bit about yourself and your journey into osteopathy, naturopathy, and then your education as a pain specialist.
Yeah, thank you so much for having me. It's really a pleasure to be here. So my journey with osteopathy started very young. I've wanted to be an osteopath ever since I was around 12. And I remember going to a cranial osteopath with my mum. And I was like falling out of trees and like I had nothing serious going on when I was a kid, but she used to take me anyway and she used to go as well, and I used to sit and watch this osteopath work with my mum. And she reported being better, and I certainly felt better after going to an osteopath. And I remember walking to the car park with my mum after a session and going, "Hey mum, I think I could do that." And she was like, "Yeah, I'm sure you could." And then I didn't really come up with any better ideas, so here I am. Yeah, indeed. There was a point where I wanted to go and study art, and that's been kind of a big, not a regret, but definitely a conflicting idea in my mind. Like, was it a good idea to pursue osteopathy? Should I have pursued art? But I think the more I look at it, the more they inform the two, certainly. Especially the way in which you have to look when you're drawing or when you're trying to create something, or the observation skills that you acquire cross over very directly to observing the body. So I studied at BCom. I graduated in 2015 as an osteopath. And during my studies, I became very interested in pain. There was quite a lot of talk with my colleagues about pain science. And my lecturer, Barry Kleinsberg, at the time, just in, I think we were doing biomechanics, he just said, "Here, there's a paper. I'm going to put it there, and I want you to read it before next lecture." And this was in second year, and the paper was Eyal Lederman's The Fall of the Structural Biomechanical Model. And that created quite a crisis moment for me in my practice. I was like, well, this paper's telling me that the techniques that we're doing don't have any long-term effects on our patients. They have short duration effects on movement and on pain experiences, but they don't make people better in the way that we think it's working. So I started to really look into this discrepancy between the literature on the structural model and making structural change, and the literature on placebo, and looking at what it is that might be going on in the clinical interaction when patients are getting better despite the techniques that supposedly don't have long-term effects.
Mm-hmm. Yeah, I think it's especially now, at least for me, I'm definitely in that crisis place where you're thinking, what is the thing that I can count on to make people better? And the point is there isn't a thing, and that thing is different for every person that you interact with, so there isn't that kind of recipe, and that's really difficult to grapple with, and especially kind of moving away from, seeing the hands-on as the end point. So I can feel where you were at that point. And I was wondering how you see your education in osteopathy and naturopathy, and then this degree that you did in pain, how those things have formed your understanding of health, illness, pain.
Yeah, it's a good question. Well, it's completely changed the way I look at people and health. Doing the Masters at UCL in pain management, it was very good for understanding how to treat pain from an allopathic model perspective. It didn't really give me the in-depth pain science that I was looking for. Like, I'm very interested in like the underlying mechanisms, what's going on in the brain, how that manifests with the body and our experience. But I used the dissertation as an opportunity to start to answer some of those questions that have been burning at me since that second year. And I think that the structural model that we kind of teach and is implicit within all of the techniques that we learn, the narrative around them is that we are mobilizing joints, right? We are doing a thrust technique on specific joints that is increasing mobility. This kind of narrative is implicitly dualistic. So it indicates that we, with our hands, are making changes to somebody's structure, and somehow that change in structure is changing that person's experience and their pain experiences particularly. And I think that it certainly can change people's experiences, but it's not the change in the structure that is necessarily changing people's experiences. And that's the kind of big realization that has really changed the way I practice. Because if it's not true that changing structure changes perception or changing experiences, like, for example, osteoarthritis patients, the population of over 60s who have osteoarthritis is between 70 to 85% of people. And not that many people are experiencing pain as a result of these really significant structural changes, right? And there's a lot of literature on incidental findings of disc bulges or labral tears or other quite significant structural changes that are in areas of the body which patients are not reporting any pain in or any discomfort in whatsoever, or even really any change in function.
So I think you're kind of defining interoception, which is what we're going to talk about a little bit more now, and I wanted to kind of invite you to maybe define it in a kind of more of a specific way, or we can just go with what you've kind of been getting at for the last few minutes, which is I think you've been describing it in lots of different ways, and what the value of, I guess, practicing this ability, the significance of that is in osteopathy and in osteopathic management and pain management as well.
Yeah. So interoception is the awareness of the interior of the body. It's awareness of our internal physiology. And I include in that definition proprioceptive sensations too. So it's not just changes in temperature or ion balance or buildup of carbon dioxide in our blood, or etc. It's also the feeling of our muscles moving, the feeling of joints moving. And the significance of learning in an accurate way to be able to understand what our bodies are doing, for me it can't be overstated. It's really, it's just such a wonderful skill to have. But let me be a little bit more specific. So, interoception, the pathways that feed into the parts of our brain that become aware of our internal world are the nociceptors and the small diameter C fibers. And these terminate in free nerve endings in all of our tissues. And they have receptors on their nerve endings for loads and loads of different chemicals that are released by our immune system, chemicals that are released when our tissues become damaged, chemicals that are released when the pH of our tissues change. They detect changes in our temperature of our tissues, and they detect generally the health of the tissues. And these nerves, they travel up to the brain via the brainstem, where they communicate with our autonomic nervous system that regulates these things. And then it feeds up into an area called the insula, which is part of our limbic system, but also part of our somatosensory system. And this directly communicates with a network in our brain called the salience network. And what this salience network does is it decides decides in inverted commas, it decides what is important to pay attention to. So what this means is that our internal sensations are directing our attentional processes. And so they are guiding what we learn to a large degree. And let's come back to the example of hunger. This is essential, right? So if you're hungry, your body is communicating that it's like homeostasis is being interrupted and you're getting closer towards death, so you need to do something about it. That feeds up through these pathways to the parts of our brain that direct our attention towards things that are going to resolve that altered state. So food in your environment, your sense of smell becomes more acute. You start to look out in your environment to seek things that might look like food. So the hunger hijacks our whole perceptual architecture to seek food. And that kind of ties into decision-making processes, right? Because the decision is made for you by your body. And there's some emerging evidence to say that people with ADHD or people who have had PTSD or people who find it difficult to make decisions have lost this ability to sense the internal world. And that means that they're not in touch with what feels right for them. Because this whole interoceptive architecture is about feeling the internal world, feeling oneself. And yeah, I mean, we can talk about emotions related to that as well, but I think I'll pause there for a moment.
Sure, no, it's really interesting because it's pain can also almost be seen as one of our vital processes as well, and you mentioned just now an example. For example, people with ADHD or PTSD, and I was wondering if there were any patterns you'd observed in people who have undergo chronic pain, who are experiencing chronic pain, and changes that they have in their interoception as a consequence of that.
Yeah, definitely. So the correlation between pain and trauma, there is a huge correlation between developing chronic pain and having previous traumatic experiences in one's life, or having previous anxiety or depression. Trauma inherently disconnects us from our feelings. So whether that's a physical trauma that's being done to us, it's useful in that moment to disconnect from the body so you don't feel it and so you can cope with that situation better. If it's an emotional trauma, then the emotion is overwhelming, and so your brain goes through a process of stopping the sensation of that emotion from taking over, again disconnecting one from the body. And that disconnection can stay, it can remain, especially if that trauma is not processed through some kind of active engagement with it and approach relationship to it. And so we can have long-term difficulty in feeling the sensations in the body, which is dictated by our life experiences. And pain is always trying to maintain the physical integrity of our bodies. It's trying to say, hey, listen, we have something that's threatening damage here. Can you do something to make sure that you protect it so that we can get back to health and carry on living? Now, if you're not aware of the internal sensations, and let's be specific about this, you're not able to differentiate different kinds of internal sensation. So you don't know the difference between stretch and pressure. You don't know the difference between muscle tension or muscle fatigue. You don't know the difference between like a feeling of hunger or a feeling of thirst. So when you don't have that kind of differentiated awareness of the internal world, it's very difficult to get the action correct according to the sensation. You may eat when you're actually thirsty. You may try to stretch a muscle that actually is really tense, and you'll be pulling hard against it, just creating more tension. And what I experience with chronic pain people a lot is they lose this ability to understand what it is that their body is communicating to them with their sensations. Like, what is the pain actually trying to communicate to them? And when we're talking about pain, it becomes a little bit more complex, because pain is also influenced by what we're thinking. It's influenced by our emotional state. It's influenced by our context and our social environment. And sometimes the pain isn't necessarily trying to communicate, like, decompress this joint or relax this muscle. Sometimes it's trying to, if only, right? Yeah, sometimes it's trying to communicate that actually you're angry and you need to get out of the social situation because you're under threat. But all of these things are integrated experiences that, especially emotional experiences, that rely on having a kind of good sense of what we feel, you know?
Right. It's interesting that you mentioned that, because I think as an osteopath, as a healthcare professional, you think that when it happens to you, you will be able to rationalize it better because you understand the processes behind what you're dealing with. But just from kind of recent experience, you realize actually when there is pain, it's pain with a capital P, and that's the only thing that your brain is going to be listening to, is not, okay, where it is, probably going to notice that. But then the only other thing that is screaming at you is it hurts. And it kind of just humbles you a little bit, because you think, I have all of this knowledge, I should be able to make sense of this and not start panicking when I get this sensation. But there's almost this kind of very primitive thing of it just hurts. And there's nothing else that exists, and you become it, and it becomes you, and then you can't remember what it was to not be in pain, and you can't remember who you were without being in pain. And at the same time, I remember an example that you gave at the talk you gave last week of a place that you got yourself to when you yourself were in pain a few years ago, and how that changed your perception. I was wondering if you could talk about that a little bit.
She's talking about the ankle experience.
Yes.
And I was angry at myself.
Yes.
Yes. Yeah, so I just want to first talk a little bit about what we learn. So you said we assume that with everything that we learn as osteopaths that we'll be better able to deal with our own pain experiences. But it's important to look at what we are actually learning. And it's very rare, at least it was in my osteopathic training, that I was ever asked, so what do you feel inside? And let's apply these techniques not to somebody else, but to yourself. And notice how your joint feels in movement, or how your muscle feels in movement, or how that makes you feel emotionally when you're exposed in this way. So I think that we don't actually practice the skill of being able to understand our own bodies. No. We practice the skill about understanding other people's bodies. So to expect ourselves when we are in pain to then be able to look into that pain and have the tools to be able to do that, I think is not necessarily true, And this has been my big journey with osteopathy really since I started to look at the difference between our structure and how to change the whole experiences of an individual. I was going, well, I have to do this for myself first, I have to be able to change my own experiences. And so I started to apply osteopathic techniques, mobilization techniques, and do them to myself. Holding onto my own joints, palpating my own body, starting to palpate myself in movement. And when you start to do that, a really magical thing starts to happen, because we practice feeling other people, so we're quite good at feeling things with our hands. But then suddenly you have this additional feedback when you palpate yourself, which is actually the sense of being felt, rather than just doing, but also doing the feeling. So you start to be able to build this really intricate three-dimensional picture of your own self in movement, right. And I think that's crucial. And because I'd been practicing that for quite a long time, and I'd also been very interested in pain for a long time, when I was with my circus friend in Barcelona, and we were it was an old monastery that we were in, abandoned monastery, out in the sticks close to Barcelona. Running and jumping over old like pits and up walls and stuff, and it's towards the end of a 2-hour session, and he's much better than I am, so I was a little bit competitive. I was like, yeah, I can do what you can do.
Of course.
Yeah, exactly right. Turns out I can't. So I ran up the wall, and there was a step underneath the wall I was running up, and my foot landed on the edge of the step, and my whole body weight from a height came down onto the edge of my ankle, and I knew immediately that it was a bad injury. Now, it didn't hurt at the time. I felt the swelling immediately, felt very taut, very tight. It felt like I had some weakness, and if I moved it towards the place of injury, then it would give me a very sharp sensation saying, stop, don't move it in that direction. So I was like, yeah, I've done a pain masters, cool, like this is an opportunity to feel some pain, do it. So
what have we become?
Yeah, really like slightly masochistic, but hey, that's a whole nother thing. So I got in bed and managed to kind of like get myself into a resting position, and then suddenly I started to berate myself. I started to just say, you idiot, like, why the hell did you go and run up that wall with this person? You know that you're not as good, etc. Everyone's going to think you're stupid. Like, and I was really imagining all my social relationships turning against me because I'd done this. It represented, and it meant that I was going to be lonely, and it meant that I was a fool, and people would think I'm stupid. And when I had that experience and I caught myself doing that in my mind, it started to be really painful in my ankle. Throbbing, aching, throbbing. And actually, now I'm speaking about it, it's starting to ache right now a little bit. I'm getting that memory of the sensation. And I thought that was really interesting. I caught myself. I was like, wow. So I asked myself the question, well, would I do it again? And I answered immediately, without hesitation, yeah, of course I would do it again. I love running and jumping on stuff. Like, it's so fun.
Yeah.
And that dispelled the anger because it had no ground to stand on once I was sure in myself that I would do it again. And the pain reduced immediately without me changing my position, without me doing anything. So what that showed me was that the unpleasantness of my experience, the suffering that I was having, not the sensations that I was getting, the suffering was a result of how I was interpreting those sensations. It was the meaning I was making from that particular injury.
Right.
And I think it requires a lot of practice to be able to notice oneself doing oneself, you know? So noticing that I was thinking in that particular way and paying attention to the direct sensations. But I guarantee that all pain is a meaning response.
Yeah, I really like that perspective as well, because we often say, in our teaching here at least, you know, pain is a physiological process, and you've got the neuroscience behind it, and you've got the pain pathways, and we're not treating pain, we're treating the conditions which caused pain to arise. But when you change the meaning of pain and see it more as a, like you said, a meaning response, a way of creating sense of something that has happened, then are we treating pain through our education and helping patients increase their self-awareness, their bodily awareness? Then do we start to treat pain if we're not just talking about the physiological process of it? And I was thinking about that a lot this week, actually. And I was wondering, are there any specific exercises or tools or any advice that you give to patients who are disconnected from themselves, and how do you bring them back to that feeling?
Yeah, how do we change meaning for people, right? Yeah, and I think it's really great that you're starting to think about, like, are we treating pain like with our hands-on techniques, or are we treating the body, you know? And I think we're treating nociception when we're using hands-on techniques. So we're changing the chemical state of the tissues by bringing more blood. We're like reducing tension, which is reducing the mechanical nociceptive information. And we can have really significant effects on that incoming nociceptive information, but that's not pain necessarily. Those are distinct different nociceptive sensations, like muscle fatigue or hypoxia feels different to muscle tension, overstretch. And again, coming back to that the pain is the meaning that we make from those different sensations. And we make meaning through life experience, through what we learn from childhood up until the place that we are in the present moment. And I think that when treating patients, there's a lot of great information now about explained pain. And I was doing that for a while before I did my master's actually, but it didn't really change people's experience for as much as I was expecting it to. And over the last couple of years I've stopped explaining pain to people.
Why is that?
Because it's very metaphorical. Often you start finding yourself talking about computers and how the computers send information from the screen to the hardware, and that is so disconnected from direct experience. And I find it so much more potent to get people to inquire into their direct experience than to give them some kind of like metaphorical or scientific understanding of what their body is going through. So instead of explaining pain, I'll get people to feel their own pain and become curious about their own pain. And I say pain is like a cake, right? Like it's made of ingredients that you can't have the pain without, but the pain is different to those constituent components, right? You can't like make the cake back into those ingredients, but you need the ingredients to make the cake. So pain emerges from these kind of sensations, and paying attention to those sensations directly I found is extremely effective at getting people to become curious about their pain and have an approach relationship to it, which then changes their behavior because they're not avoiding those things that are painful anymore. They're becoming curious and playing with it. And I think if we can instill an attitude of curiosity towards pain experiences for patients in the safety of a clinic environment, then we go such a long way to changing their relationship to themselves. And inherent within that is learning interoception. Going, okay, so if you load your knee in this slightly different way with your foot externally rotated, is there a different sensation to when it's internally rotated? And if you do it with, like, I don't know, your arm up in the air, is that a different sensation to when you do it without? And what is that different sensation? And that's such a crucial question, I think, is like, what are you feeling? Like, what is that actual sensation? Because inherently within that question, you have to inquire into your internal world, separate out the milieu of different sensations that are there, and then put them into words.
So what are some words that you've heard to describe different sensations? Because I'm just thinking back to some people that I have seen who have had back pain for 30 years, and you ask them, so what exactly does it feel like? And they just go, pain. And then you try to ask, and they go, pain.
Yeah.
Because it's become just a big blurred mess, and I don't doubt the fact that they cannot put any other words on it, because there's a point where it just becomes a bit like white noise, I can imagine.
Yeah.
So would you give them like spurs or kind of examples of things they could say, or would that influence them too much? And if you would, then what kind of things have patients told you over the years?
Yeah. So I had somebody this morning who's been suffering with like back pain since a disc herniation for 25 years. And he just says that it's constantly there in his right side of his back. And you'll hear this kind of descriptions from patients all the time, like it's just pain, or it just hurts, or it's just there. And it's like, well, what's there? Like, what is that? And that's the kind of question that I will ask. I'll be like going, what kind of pain is another question I ask on a regular basis. And if they go, well, I don't know how to describe it, what that tells me is that they haven't got a good awareness of their internal world. Because I believe, and I would love to do some more research on this, that the more vocabulary we have to describe sensations, the more we have inquired into and attempted to describe those sensations. And therefore, the more we're aware of the body. And sometimes that can be through a lens of fear, which is then a different thing. The question is then, what's your relationship to those sensations? Are you scared of them, or are you curious about them? But for the patients who really don't know, who just come in and it's either pain or nothing, I tend to use the opportunity of assessment through palpation to get into the body a little bit more. So if I'm palpating their body and their muscles are super tight, I'll ask them, well, what do you feel there? And often they'll go, pain. If I move to a place that's not tight, they'll go, no, I don't feel anything there. I feel nothing. And so I ask the question, what is nothing? You know? Because if it was really nothing, then I'd be very concerned, because you would be like paralyzed, right? But what is the nothing? What is the normal that you're feeling?
It's very interesting you mentioned this. Good friend of mine, Maya, I'll just shout her out on the podcast. She was saying, actually during your talk, she was whispering to me the whole time. She was going, I can't believe I've never thought about these things before. And one thing that she mentioned was that let's say we as fourth year students at the very beginning of our journey, we are entertaining this duality of pain, no pain in our questions. Do you get pain when you do this? Does it hurt here? How does that feel? Does it feel okay? Okay meaning the nothing kind of that you were talking about before. And we're entertaining that. And we were both just sort of looking at each other like, it's not for no reason that patients then tell us, no, I don't feel anything there, because they are expecting us to be asking about the pain. So I think it's also a lot of reflection that we can do on that as practitioners.
Yeah, and if you only ask about pain, you're only going to get information about pain. And patients will respond to the questions that you ask. And I think it's really worth reflecting as a practitioner, like, what questions am I asking my patients? What information is that really giving me about the totality of the body that's in front of me? Meaning, am I just getting information about pain? Or can I get information about all the other sensations that are possible to feel? And what's my patient paying attention to in my sessions? What are they learning from my sessions? Are they learning that they have agency over themselves? Are they learning through the way I'm questioning them and directing their attention what these different sensations are? Or are they just learning pain or no pain?
Yeah. And it's through our journey with them that we are, I don't like saying this in this way, but educating them. You're kind of both educating each other in a way, as to all the nuances of what a human experience can be. I think that's one of the most kind of rewarding things about working with people, is that you get to see all of the different sides of what it means to be a human being, and you see the pain, but you also see recovery, concern, grief, loss, hope, and at least to me, taking that as the reward by just learning about people and being able to be with people means that regardless of whether or not there is pain, the experience is always a learning experience, and a positive one, because we're just learning about what it is to be alive in this world. And similarly, that's kind of more from a selfish standpoint as a practitioner, but also for patients, you're doing a similar work, it seems, by getting them to understand the multiplicity of what it means to be a human with a moving body. I was wondering if there were any kind of challenges or considerations to have when using interoception-based practices with certain patients, anything we should be aware of?
Yeah, so I want to just speak to what you were speaking about a second ago.
Sure.
So I think the crucial change in perspective that you were asking me about at the beginning that I had kind of the change in perspective and the change in intention of the sessions that I have with my patients is that I don't want to change their body, I want to change their perceptions. Because I believe that pain is a perception. And in order to change people's perceptions, there has to be learning on both parts. We as practitioners have to learn about our patients' perceptions, and the only access we have to those perceptions is what they say to us via their bodies, but also via their words. And you can guarantee that they do not perceive the world or their bodies the same way that you do. And so we have to become very, very good at active listening as a fundamental skill. And active listening, I imagine it like trying to step into that person and trying your very best to understand what it is like living inside that person, as it is for them. And so any places where you feel unsure what it's like for them, you have to ask and inquire deeper. And I think if we look at that lens of trying to change patients' perceptions as opposed to trying to just change their bodies, mobility, like healing, etc., we find that perceptions are built from the body a lot of the time. And we can use the tools that we have, the techniques that we have, to very effectively change people's perceptions of their body, their internal world. But we have to engage their attention while doing so. So we have to get them to be involved and plugged in to the treatments that we are giving. If we really want to change their perceptions and get them to learn about their own body, we need to get their attention inwards. And they need to be continually inquiring, what do I feel? What is it that I feel in myself when you do that, or when I move this way? And the danger with that is, I think, that we get people in touch with feelings. And some people haven't been given very good tools to be able to navigate feelings.
Right. So in that case, if you did have a situation where you are guiding someone into themselves more and they haven't visited that place for a while,
or had trauma, and so have been prevented from visiting.
Right, and finally accessing that, how would you then guide that part that becomes quite difficult for them to bear if they're now facing these things that they've not been able to?
Yeah, so we have to start with ourselves. We have to ask the question, when I feel difficult emotions or difficult feelings in my body, what is it that I do? And can I regulate that without distraction? And what you find is that the negative emotions that we have, or the feelings that we find difficult or scary, the process of avoidance and the process of suffering from the feelings is often a process of activating sympathetics and attempting to run away from or to collapse in the face of. So I find that starting from a place of really knowing how to regulate one's autonomic nervous system is essential. And through that regulation of one's autonomics, being able to use breathing to slow heart rate, for example, by slowing down the out-breath, by choosing relaxation, by learning tension and then release, then we can teach people how to regulate those kind of really intense feelings and states that change. And when you have a little bit of taste of being able to regulate it for yourself, it feels much safer to approach. So starting with the ability to regulate one's autonomics, starting with the breath, is the most effective way that I've found to start to approach feeling the body in a way that is safe for people who find it very difficult to feel their own bodies. And that's built from a foundation of a really good relationship between the practitioner and the patient. They have to really trust you. And I think that the more in which you are comfortable in yourself, the more in which you are comfortable with your own difficult feelings, the more safe that you'll feel for other people to feel difficult things in your presence. And the more you'll understand what they need and how to regulate it for them.
It's a really beautiful thought, and it kind of, I guess, brings us back to what you said at the start about how we're not necessarily taught when we're learning this practice how to feel things within ourselves. And it's very important that I guess we keep coming back to our own ways of coping and our own sensations so that we know how to respond. And just picking up on something that you said at the end there made me think about something that I've noticed over the last few weeks, how all we talk about when we're learning how to help people is pain. How do you find it? How are people going to describe it? What does that mean? How do you assess it? How do you fix it? But when someone comes to you and they're, I don't know, like fidgeting on the chair, or they can't even sit down because they're suffering so much, and you're not even there, they are in so much pain. As a practitioner, I've felt, at least at times, really paralyzed by that, by seeing someone in pain, in that much pain in front of me, because you don't have a vial of morphine to just go pop and then everything's going to feel better. You don't have that. And also, pain is always going to be that invisible thing. You can't say, yes, you think you've got a rash, I'll have a look. Yes, it is a rash. It's something that's invisible to everyone who is discussing it, and even the one who's experiencing it. And you have to be so brave to be able to bear witness to someone who is suffering in front of you. And like you said just now, it takes a lot of self-awareness and I guess resilience and experience to be able to hold that space in a reassuring way. I was wondering about your thoughts on that, actually, how you cope with having to be with people who are constantly in pain. That must take a toll on you as well.
Yeah, it does. And I think there's a couple of things I want to mention. Like, if somebody's in acute pain and they're really in a lot of pain, you first got to ask yourself the question, like, what the hell is driving this, like, make sure that this person is safe to treat, and that their pain is something that you can actually handle with the tools that we're given. And often, if we're talking about acute pain scenarios, they're driven by nociceptive changes. And it's the body communicating to the brain that something is damaged or something's really wrong, and a healing process needs to be initiated. So often the most painful things are things like nerve compression injuries, or like tears to muscles, or infectious problems that have a lot of nociceptive feedback. And there's often some things that you can do by changing the body's position, or changing the loading to those tissues, or providing medication that can reduce that person's suffering. And that's when we have to use that understanding of biomechanics and the understanding of the body that we have. And that's a different problem to how we feel in the face of their suffering. And I think it comes back to why I chose to be an osteopath. And I think a lot of us choose to do these kind of healing professions because we're driven to take care of people. And I was certainly driven to take care of people because I had to growing up. Or I felt that I had to growing up. I had to take care of my little sister, had to be a carer of my parents in a big way, even though I was the child. And that led me to a relationship with caring, which was, if I don't care for other people. If I don't take care of their needs, then it's very difficult for me to exist. It was an existential relationship with caring. And I think that's why I chose to be an osteopath, was because I saw my mum becoming better as a result of going to an osteopath. So I was like, that's a way that I can exist, because if she's better, then I can be myself properly without needing to take care. And that relationship is really taking responsibility for that person's suffering. And if we are taking responsibility for that person's suffering, it's really never about them. It's about us, because we want to feel better, because we feel like we have some kind of need to change this person's state. We need to take care of their suffering. And it's a very, very fine line to tread between being compassionate for their suffering and empathizing, or being driven by a sense of inadequacy to be able to change their suffering.
Cutting some strings there. Yeah.
And I think it's essential, if we're going to do this job well, that we need to understand why it is that we are driven to take care. And is that driven by an inadequacy or a self-criticism, or is it driven by true compassion for that individual? And if it's compassion, then there's a separation, and you can still exist, even if they're not well.
Yeah. Do you feel like you've managed to find that balance? Is it a balance that often goes out of the balance, or is it a balance that stays stable?
It's a good question. I'm finding it. I'm finding it. But my whole life I've been taking care of people. And so the amount of practice I've had at being the one who is the carer, like changing that habit is taking time, you know, and putting myself more in the picture and understanding my own needs in the face of other people's needs, and standing up for my own needs in the face of that, is something that only recently I'm able to now do.
Right.
And there's trauma linked into that for sure. Like there's some really difficult experiences I've had when I was growing up that cemented this process. So it's been a process of reintegrating those traumatized parts of myself and really fully embodying and experiencing what that was like, and now owning that, recognizing that it's mine and that I have the capacity to hold all of that within me. But that takes a lot.
There's a lovely quote by James Baldwin that I like, and it goes, I'm sorry, James Baldwin, it's probably not exactly how he wrote it, but it's something like, it's by reading books that I realized that suffering unites everyone and everything that has ever been alive and that will ever be alive. And kind of seeing yourself not as separate to your patients, but as, again, just part of a macrocosm of just people wandering around minding their own business. And it's interesting also thinking about family as well. I've had this almost a bit of a mental block when it's either I have a health issue or a family member has a health issue, more like a, something that an osteopath could help with. I get a bit of a mental block, and I think I've realized that it's because something in me goes, you can't be a patient, you're a family member, you're not part of that part of my life. You have to stay separate because you're my family, and you can't be like a finite human being like all the rest of them. And again, that's your brain trying to just compartmentalize things and try and, I guess, protect yourself when you have all of this knowledge. Anyway, but yes, I was wondering what kind of tools you would use for yourself to improve your resilience in the face of these experiences, and also how you cope when people don't get better.
Yeah. Well, I didn't cope for a long time when people didn't get better. Took patients home, blamed myself, always asking the question, what more could I have done? And suffered as a result of it for a while. And I think it's a normal part of a graduate's journey that we don't speak about enough, to have that relationship with people not getting better or people not coming back. It's difficult. We take it personally, and that's okay. And I've learned to recognize that part that criticizes myself for not doing things right, that makes me suffer quite a lot, is an extremely potent learning tool. And trying to imagine myself without that part of myself that criticizes me, or without the part of myself that suffers, I think is a really interesting mental exercise. It's like, okay, if I never suffered, where would I be? And actually I imagine myself not being motivated to do anything, and there being no learning or no progression. And I think it comes back to that approach relationship I was talking about, that curiosity about suffering and pain. If we are curious about our suffering, it doesn't mean that we don't suffer, but it means that our relationship to suffering is one of approach and learning, rather than avoidance and fear. And if we have that fundamental attitude when we suffer, there is learning that can take place, and that suffering becomes a gift, actually, rather than it being something that is in the way or hindering us. But it requires an ability to direct our attention where we choose to direct it to. Because sometimes we have to direct our attention inwards to our own thoughts or our own feelings. And I think this is why I really encourage people to inquire into their own sensations, their own interoception, because it trains that muscle of being able to choose what to pay attention to. And if we are able to pay attention to regulating our heart rate through our breathing, if we're able to pay attention to how our posture changes in the face of emotional content, or when we're criticizing ourselves, how much tension is in our muscles, is our mouth dry, has our autonomics changed? If we can build that into our awareness, then we're able to use those physical aspects of these things to turn the volume down. If you're super tense, your head's forwards, your throat's tight, you're not breathing properly because you're thinking about what that you did with that patient that could have been better, and you notice that, you're like, oh wow, okay, let me breathe deeper for a second. Let me try and relax my shoulders a little bit. Thank you, body, for giving me this reaction that's trying to protect me against this thing that I'm scared of. And then we build compassion, because if we're aware of these things and then we suddenly see a patient walking in the same posture that we're adopting when we're anxious, you're able to see so much clearer what their experience might be, and start to do that bridging the gap of that active listening. And because you've noticed your own experience, you have a better map of what they might be experiencing. Right. So it builds compassion at the same time, and empathy.
It's a beautiful point, and also the value that receiving treatment as a practitioner as well. This year, just experimenting a little bit more, kind of putting the handbook to one side and thinking, okay, let's just do what feels like it should be. I guess coming back to that point, or the discussion we just had about caring for people, caring about people, I think there's a point maybe when you become a practitioner where you stop seeing yourself as someone who receives treatment as well, who can, and you stop thinking about, actually, what would I need if I felt like I was slowly curling up into a shrimp position because of all of the weights of my problems. And then when you are able to lay down and have someone take care of you as a practitioner, then can you just put your hand on my sternal angle and just do this and do that? And then you start to figure out techniques that actually a lot of your patients might also benefit from, considering how you understand them and your understanding of yourself. So yeah, on an emotional and a physical kind of treatment level, I think that applies too, which is really interesting. And I was wondering where, because you said that the degree in sort of pain management that you didn't touch so much on the pain science part of it, but now you've gained a lot more experience since then. I was wondering where you feel like pain care is evolving towards in general, or maybe more specifically on your journey, where you would like to continue to take your journey.
So I think pain is becoming more prevalent in the population, because we live in this kind of modern day society where we're not living as we've evolved to be anymore. We're not exposing our bodies to chaotic positions or chaotic environments on a regular basis. We're not moving. We are distracting our attention by focusing on technology a lot. So we're not training the muscle of being able to feel ourselves and respond to that with accuracy. And the body will complain. It will.
Maybe that's the sequel to The Body Keeps the Score. Is The Body Will Complain.
Yeah, literally. And it'll scream at you. It will. And if you don't know what that scream is saying, then your body's gonna continue to scream. And we're building a society in which we're creating the perfect environment for that to be the case. So the way I hope that pain treatment goes in the future is to begin to teach people a curious relationship about their internal world and about discomfort. So begin to be curious about pain, and create an approach relationship to it. Not in a masochistic way.
That's for the next episode.
Yeah, unless that's your bag and you like that. But hey, I'm not here to judge. But in a way that moves you back to a state of homeostasis. Because ultimately, I believe that pain is a command by the body to try and help to alleviate pain, to move from pain to pleasure, and if we can get people to be curious about how that happens and experiment through moving their bodies with their pain, I think we've done the world a massive service. And I want to move my personal practice more into natural environments. I would love to bring chronic pain patients into nature and teach them how to move in nature and be in touch with nature once again, and remind their bodies that that's what they've been designed for, which is hard in London.
It is, but that sounds like a really wonderful endeavour, and I hope that it works out like that, and for all the people that will be lucky enough to be in your care. I just wanted to thank you for everything that you've shared. I'm definitely very inspired by what I've heard, and I wanted to just invite you to share where we can find you. If you have a website, I know that you're doing a CPD course in March. Is that right? If you wouldn't mind just telling people where they can find you, because I'm sure they will.
Yeah, so if you want to know more, I am running a CPD course that will go through a lot more in-depth neurobiology of pain, and really take people through more concrete, practical applications of it in treatment, like how to use the understanding of pain to change people's perceptions in the clinical setting, starting with oneself, as usual. And that course is happening at BCom in March, and you can find it on my website, which is www.feinhealth.co.uk. And yeah, I would love to see people there.
Great. I'm sure you will. You'll definitely see me there.
Great.
So I wanted to thank you for your time, and thanks to the University College of Osteopathy for letting us use their premises, and we'll see you on the next episode of Table Talk.